So at this point, we have a real treat. We're going to move to a plenary session address. It's been pre-recorded. Our plenary session presenter is Matthias Udker, who received our leadership award last year, who's a brilliant imaging scientist in the Netherlands, who works with an incredibly talented group of computer scientists, epidemiologists, clinicians, radiologists. It's a wonderful team. And they have been involved in cardiovascular imaging research for the last 3 decades. And we're going to get an overview of the distillation of this moving into thoracic CT screening in a very serious way. And without further ado, I think we can move right to that video. And I'll just give you a heads up. It's recorded. Fortunately or unfortunately, Dr. Udker is in the air right now, flying to China, to Shanghai. So this was this or, so we took this, and it's a wonderful presentation. We have a little panel discussion after this that we'll see. And then after that, we have some time for open questions. We will do this in absentia. Professor Udker won't be here, but he has given me his proxy vote. But there's lots of issues that we have lots of expertise across this group that you'll see that there's images, there's issues that emerge that we want to talk about, and then we'll move into the rest of the proceedings. So we'll get to the award ceremony actually. So without further ado, let's move right to that video.
Thank you for the opportunity to have a presentation here at this 21st time of the quantitative imaging workshop. And I am also quite pleased by the fact that it is on the cardiac risk assessment in asymptomatic individuals. So I will show the preliminary results of the 2 major studies that we are performing at the moment. That is the Robinska study, where we are at the point that we are going to open up the final results, and the Fornalearn trial that is really running at the moment and will have comparable, will allow for comparable analysis as the Robinska, but even more in the relation to lung cancer screening itself. We go now, wait a minute. Those are my disclosures. Now, first, and I think this is already known by most of you that are in this field, the comparisons of performance of those tests for cardiovascular risk stratification is shown here. This comes from a very important publication of Hecht in 2015, where he compared the many different analysis and tests that you have to stratify the cardiovascular risk. And here it is shown that compared to invasive test, the best non-invasive test is the calcium score. And now from this, we were also involved in a study that we did with EBD systems already in the beginning of from 2000 in the Rotterdam calcification study. And from those results, we got very interested in further working up this in a new study, which is, of course, the Robinska study. And we knew also from our own experience, but also from the publications from the US, that the calcium score is the most robust predictor of coronary events in asymptomatic primary prevention population, and particularly in the intermediate risk cohort, which we can discuss later. And it has, of course, also demonstrated its superiority, as I shown before, compared to the framing and risk score, and also a better stratification. But we would like to confirm that also in the European population. Now, furthermore, the calcium score could improve medication and lifestyle adherence and is cost effective in specified populations, and that's one of the assumptions in this study. And furthermore, it's strongly associated in the development of stroke and congestive heart failure. But the highest is, of course, with the MACE rate and cardiac mortality. At the moment, there are still at this moment, no outcome randomized trials demonstrating its clinical benefit in terms of survival. And I think that's an important point that we would like to address. Now, in 2008, just to make clear that the radiologists also do something, we published guidelines together with the North American Society of Cardiovascular Imaging and the European Society of Cardiac Radiology on the value of the zero score. And at that time, we were far ahead of anything that had been published in the cardiological community. And we stated that the absence of the calcium score is an excellent filter for exclusion or of obstructive cardiovascular disease, also in symptomatic patients. And that was in real debate at that time, and still, I think. So not only in asymptomatic, but also in symptomatic patients. And the presence of non-calcified and potential obstructive lesions is higher in patients with low calcium score and symptoms compared to patients with as compared to patients with a score of 0. So yeah, that is also, I think, a very important point to debate for those people that are younger than 50, have indeed a 0 score and still develop a soft plaque which is not calcified. How do you detect them and how can you find those? 10 years later, the cardiologist came up with a clinical practice guideline and also stressed the value of the 0 score, which is, I think, very important, and gave many recommendations on how to act on the calcium score. Now, the questions that remained after this recommendation: does early detection and treatment in high-risk populations of cardiovascular disease indeed decrease morbidity and mortality rates? And that is one of the key questions of the Rubinska. Is long-term impact when 50% of the population is eligible for statin therapy, and that may be lifelong, acceptable? So that's also a very important question to address, and that is still not, I think there's no answer to that question still. Will most individuals, so 70%, treated with statins not have successful treatment in terms of CV event and CV event reduction? Now that's, of course, also a quite important question. Now, we said at the time that if the 0 score could eliminate so many people that have no chance of getting cardiac infarct to come in 10 years, as has been shown also by the MESA study, then the 0 should be 0. And most of the data were indeed based on the EBT with an extremely high time resolution beyond the 50 milliseconds. And the monosource systems and also the dual source systems had at that time not near to such a time resolution. And the time resolution is really key to get a reliable calcium score. So I had for 1.5 years all those systems in my department, so a 64 one, a dual source, and an EBT. And then we did comparative phantom studies. And if later on we did also comparative studies with multi-detector, dual source, and EBT in respect to the analysis of all kinds of different aspects in terms of linear motion, calcification density, temporal resolution, also in the phantom study. Then later on, we worked with dual source systems, and we compared the first, second, and third generation dual source systems, also in a comparative study. And we saw that the Eggleston score and MES score differed by 12.7 and 5.6 respectively from when you go to the first, second, and third generation dual source. So therefore, it was mandatory also for the Rubinska trial to come up with the best protocol that could be installed compared to the outcomes that we had from the MESA study. So calcium score determined by an ECG triggered. So, and that is very important difference, but for what we did later on, with the dual source CT systems and 64 slice systems are highly susceptible to motion artifacts as compared to EBT. So that's one thing that is important. The MES score is less susceptible to motion compared to volume and agonist score, but the MES score has no introduction in any clinical decision making so far. The calcium scores determined on ECD trigger dual source CT bear closer resemblance to EBT compared to single source multi-detector systems. So that's one of the very important conclusions we had at that time. Now here you see 27 studies in this graph, and most of the studies give you a reduction of the dose of 25%, and some of the studies work with a reduction of 50% and very few with a reduction of 75%. And with those with a dose reduction more than 50%, the reclassification rates ranging between 3 and 21%, because a lack of data is a little bit strange mentioned here, but because the data that are acquired are lacking in that sense, that the density, when you have a very high pitch, or the density of the volume measurement is less. Iterative reconstruction and spectral shaping have a negative impact on the calcium detection and risk stratification. So from our perspective, in iterative reconstruction and spectral shaping are really forbidden to have a reliable calcium score. And what is, of course, important, there is somewhere a lower limit. You cannot reduce the dose endlessly. And we think and that is just expert opinion, so not proven, that the reliability of the calcium score stops at a dose at 0.5 millisievert. If you go lower, I will show some examples. If you go lower, the calcium score becomes really unreliable. Now, the cardiovascular population-based ECG-triggered dual source CT screening is feasible with a standardized and validated imaging protocol. So that's where we worked on those protocols. And at the end, and here I have a typo, the optimizing scan parameters with second generation ECG-triggered dual source CT significantly reduces radiation dose, and that is what we used in the Robinska study. So that's the flash system. The radiation dose reduction that we could achieve with still good repeatable and standardized calcium scores went up to 73%. And yeah, CT protocols are feasible with doses between 0.5 and 1 millisievert with this protocol, as long as you trigger them with ECG. And as I stated before, if you go lower than 0.5 millisievert, the signal to noise ratio becomes deteriorates more or less. So if we go to the Robinska study itself, so we developed this protocol for the Robinska study. The key question is, can we prove? And it's a large study, 40,000 people. It has been finalized, so those are the numbers that have been realized. So the usual care, that will differ, of course, but the usual care in the Netherlands is what the GP does according to the guidelines in the Netherlands. 14,159. The systematic coronary risk score, that's called the score chart in Europe, comparable with the Framingham score. And that is 14,478. And then the arm where we act on the calcium score alone. And that's the intervention arm B, also more than 14,000 participants. Now, the baseline characteristics are seen here in the calcium screening arm. We did a little bit more than was projected. And the CVD risk factors you see here at the right, 20% recurrent smokers at baseline, 3.4 reported diabetes, 16.4% reported with hypertension, 15% reported with hypercholesterolemia, and almost 45% had a family history of cardiovascular disease. Now, I think the results of the calcium score in this cohort, and these are already the results, the calcium score was absent in 40% of cases, almost 40%. 48% of women had a 0 score and 21% of men in the same age category. So that is, in women, very high. So also the development of the calcium score in women is, in the coronaries, develops with the same scores if you look at the charts around 10 years later. Now, 70% of the women had a calcium score higher than 100 compared to 40% of men. So here you say, if you look at the same age category, you see all the time those differences. Diabetes was a strong predictor for calcium extent in both sexes. That is what we know from all studies. So that also have been proven quite widely in the US. And yeah, that is not what we thought, but the BMI is not a strong predictor for the presence of calcium. While the waist circumference is more predictive for calcium presence. Then in women, age, smoking, and family history are predictors for higher calcium scores, more over the 400. And in men, lower socioeconomic status, indicated by educational level, significantly predicted a higher extent of calcium. So that really goes hand in hand with what we find in lung cancer screening. Then, in the comparison of the two intervention arms, we find a lot lower rate in the calcium than in the score chart. So the freemium score, you may say. We find also a difference in the indication for preventive treatment, a lot lower in the calcium than in the score chart. And so the increased risk is really not related for the indication for preventive treatment in those cohorts. Now, again, the score chart, so the freemium score, you could say, versus the calcium score. And then you see the difference in the screen arm. In the score chart arm, we find 45% of low risk. And in the calcium arm, we find 76. So that is really a huge difference. The intermediate scores differ from 26% in the score chart and 15% in the calcium screen arm. And at high risk, you see also huge differences in the score chart, almost 30%, and in the calcium arm, screening arm, not even 10%. So those are huge differences. Now, the differences in the individual at increased risk you see here. So altogether, and then in women, we find an increased risk in 46 in women, 63% in men. And with the calcium score only almost 70% versus 31% in men. So huge difference again. And if you look to the relative reduction, it's all over the 50% compared to the score chart. So that is, and the absolute reductions are around the 30%, which is still quite high. Now, the indication for preventive treatment, you see also huge differences here in relative reduction rates. As you can see here, it's up to 40%, and in men up to 30%. So that is also, I think, quite impressive. And in conclusion, at the Rubinska baseline, we find that the largest population-based RCT, of course, that is the Rubinska, we find that in 31% of men, 70% of women, a calcium score of 100 or greater who require preventive treatment. And that is a lot lower than with the score chart. And that means that also at the level of preventive treatment, we could have a minus more than 30% decrease of preventive treatment in this population. So I think that is already a very interesting result. So I would like to, now this is, if you want to republish this, you can just have a look at it, very detailed in the publication. And this is also already accessible for further analysis. So I'm not going in this in detail. So the calcium score significantly reduced the number of individuals indicated preventive treatment compared to the score charts for the framing score. These are the same numbers, but then in a graphical presentation. So again, to stress the importance. Then we come to the setup, really, of the impact definition of the study. If we can prove in our study a morbidity and mortality reduction of more than 50%, it would impact in the Netherlands a decrease of 500 persons annual mortality that would end 30,000 annual hospitality admission decrease. So that's the Netherlands, small population. For Europe, it would mean 110,000 persons annual mortality decrease and 500,000 hospital admission. And for the USA, it would mean 83,000 persons annual mortality decrease and 157,000 annual hospital admission decrease. It does not mean, so the setup from all the current evidence at that time was a 50% reduction to prove a non-inferior or even a better performance of the calcium score in terms of morbidity and mortality degrees in comparison to the score chart. But it does not mean that the study would not power for a 10% reduction. But we said, okay, 15% would be kind of a lower threshold. So the risk of benefit that should come out from the Rubinska study is, on one hand, the risk of screening and risk of medical interventions, the false positives, the overdiagnosis and overtreatment, the collateral disease detection, and unjustified reassurance and reverse lifestyle induction. So those are the risks. And the benefits would be mortality decrease hospital admissions, life years gains, increase of early treatment and options combined with decrease of overtreatment. But now we have as a very important side effect, what we showed here already, that the zero score will give an enormous decrease in treatment indications compared to the score chart of the framing score that is usually used in cardiovascular practice. Now, the Rubinska outcome showed a zero calcium score will be found in almost 40% of the population. So it is a relevant finding, which is also, I think, very important, with the average age of 63 years. And it rules out clinical relevant cardiovascular disease the coming 5 to 10 years. Now, the impact I already have told in the beginning that will be already huge with this outcome. Then we tried to from the acquisition point of view, to translate our protocols of the Robinska to a non-triggered ECG. So in the Robinska, everything was done with the dual source system, which was ECD triggered. And now in the foreign learner study, we do a combined protocol, which is exactly the same as we used in this study, which comes from EMALife, which is a study in a population that is following aging in time in normal population, and we implemented also those questions there and CT imaging there. And we found here, and that's, I think, very important, that if you don't trigger it anymore, but you speed it up, so this is with a third generation, while the Robinska was with the second generation triggered, and this is third generation triggered versus non-triggered. And then we find that we had an underestimation of the calcium score with non-triggered chest CT, and you find that here. So that are the 20 and the 27 and the 8. And those together will, from the total population, which was 1,000, as you can see here, those would have an underestimation. So they would go from to 0 when they with triggered, they would have a score between 1 and 99. To 27 would have a lower score between 1 and 99 non-triggered. And that would be, if you trigger it, between 100 and 400. But we have only 8, which would have a lower than 400 scan if you do not trigger, and would have if you trigger a positive, so higher than 400 calcium score. So it non-triggering underestimates the calcium score, but still it has a very high sensitivity and specificity. Oh, and a side information that we found, that a patient with a BMI is higher than 30, those results become less reliable. Now, this is the imaging protocol that we used in foreign learner. And so this is a non-trigger, exactly the protocol that we used which you could see in a former slide. With a high pitch. So it's a 1 run, full test, a chest, CT data acquisition without ECT triggering or beta blockers, implemented in a lung cancer screening setting. And yeah, this is typical, of course, for the reconstruction parameters that we use in the with the Siemens systems, with the different recon protocols. And this is what we use for the cardiac reconstruction afterwards. So it's the QR36 for those that are familiar with those protocols. And here you can see that we use very low tube current. We have a voltage of 120, a matrix of 512, and we use dose modulation, care dose, to reduce the dose as much as we can. Now, so this is all also published, the way we do this. And then we go to the next slide. So we have the results in 3,626 participants of foreign learner. And there we have a mean dose, which is very important in Europe, and especially in Germany, for this 1 run. And so we do not do a dedicated cardiac examination as in Robinska. So we do a full chest within a second, and without ECD triggering and beta blockers. And there we find mean dose less than 1 millisievert, which we think is really great that we could this way. A maximum dose of almost 3 in the very obese patients, and a minimal dose of 0.3 in the very thin patients. We did also some reproducibility of the calcium quantification. So we did a baseline and 3 months comparison in almost 500 participants. And we saw in 94% almost no difference between the two classifications. So if we look and we think relevant downgrade classification rate, that is only in 1.6% of the population. So I think this is, really a surprise for us that we could have such good standardized and reproducible results with this protocol, which is important because this would give us the opportunity also to translate the Robinska outcomes to the foreign learner study. Now, not all of those downgrade problems are caused by the acquisition. So here it's also from AI classification error, as you can see here. So the classification here in the entrance of the ostium of the left main is here classified as coronary calcium, and then in the follow-up it's classified as not related to the heart. You can see it here. So the classification rows is bone, and that is also there at the same. So here you get in the left main 275 as Eggleston score, and that's related to this thick calcium plaque at the ostium of the left main, and here it's only 9. So that is a classification error not related to the acquisition. So that's also something we are going to further analyze. And then in almost 2,500 participants in the foreign learner, you can appreciate here the stratification. So we find here overall in 60% a high risk, that means over the 400. And then, altogether in the first cohort, we had 30% of participants with significantly high risk. Then 54% were suitable for preventive treatment, so half of the population. So that's also interesting that we, in this lung cancer population, we find more than 50% that are, but we had, of course, in foreign learner, a more high risk population with an age over the 60, as you probably know. And then here we had also in this category of these elderly patients for almost 50% with a very low cardiac risk. So there is something like a happy smoker. So in summary, we can indeed integrate cardiovascular screening in a lung cancer screening program with the latest CT technology. So with this 3rd generation non-triggered one-run protocol that we tested already before, which indeed gives some underestimation, but that is not going over the 10%. It's a lot lower, so around the 6% maximum. So the CT quality assurance in the one-run non-ECD triggered the dual source data acquisition is mandatory. So this is where I think the work also from Rika Vila and comes in, where we really have to work on the regular measurement and testing of the quality of the data acquisition. We should also have a look at the way the AI is doing its job in terms of characterization of the plaques, as I showed. And rigid acquisition CD protocols are a prerequisite for radiation dose limits control in LC screening. So what we fear is what we also see in the Netherlands, that just with monosource systems, non-triggered, there comes false reassurance of negative CTs. 1 out of 3 participants in lung cancer screening had a significantly high cardiovascular risk. Half of the lung cancer screening population are candidates for preventive treatment, as I said before, and 50% is at low risk. So this is the current situation and outcomes, preliminary outcomes, which are still not published, but are in the process of, the first cohorts we will probably publish the coming years. And we also expect, of course, the outcome in mortality, morbidity, MACE rate of the Robinska study on short notice. I thank you for your attention, and I think, it's open for discussion.
Thank you, Matthias. That was a wonderful summary of incredibly important research that you and your colleagues have done. We're now going to move to a panel discussion, and to help us with this, we have two distinguished faculty members, and I'll ask them both to introduce themselves. We will start first with Professor David Yankelevitz.
Well, thank you, Jim. I'm David Yankelevitz. I'm a professor of radiology at the Icahn School of Medicine at Mount Sinai, with a long-term interest in lung cancer screening and the integration of coronary artery disease into that process. And I just want to say that that was just a wonderful presentation. I'm looking forward to this discussion.
And I'm David Marin, professor of medicine at Stanford University, and a preventive cardiologist and clinical trialist.
Thank you both very much. And Matthias, there's so many issues, and there are technical issues, there's clinical issues, and there's, I think we'll try to partition it so it makes sense. Let's start with the technical issues. It seems that what you were saying from your comparison of the Robinska with the lung run, that you would expect that calcium analysis done in the settings of most lung cancer screening going on in Europe and the United States, that if you have a positive calcium result, then that's likely to be important. But if you have a negative calcium result on your analysis, that would potentially be a false negative. And so you would not want to have false assurance. Now, given the data that you just presented, even with that imperfect characterization, that kind of stratification would still have a lot of value. And have you thought about how that would be played out in Europe, where you already have deployed force of CT scanning capabilities, which is not, third generation?
Now, at the moment in Europe, the situation is such that everything is focused on the lung cancer implementation alone. So there is not even a slight awareness of the combination of both. There is also no initiative for this combination, but it's starting now in the Netherlands, because it has to be brought to the attention, more or less, or to the awareness also of in the medical field, that this combination is possible. And because we went through, I think you are all aware of this different legal system that we have for population screening in the Netherlands, which is unique worldwide. So population screening, if it's regarded as useful, will be paid for by the government centrally and will be offered to the total population. So that means also, if you want to do a study, you have by a different law to apply to the Minister of Health. So that is what we did for the Nelson, that is what we did for Robinska, and that's also what we did now for Foreign Learner. And they will then decide based on an advice of the Dutch Health Council, if they would allow the trial, what we are doing now, and the implementation of such an approach. And so it was approved now. I think that is for us a major achievement, and that is also unique, I think, anyway, in Europe, that the minister allowed us to also report on calcium scores higher than 300.
Yeah.
We are
Now,
not, we are
well-
not allowed to reassure patients with zero scores.
okay, interesting, interesting. Okay,
Fine. So
do we have
there
any?
need approval of the Robinska.
Okay, thank you. Oh, okay, so the further information will be useful. Okay, thank you very much. Professor Yankelevitz, on the technical side, do you have any issues you want to go back to from that elegant presentation?
Oh my goodness, I have I have a lot of things that I'm very curious about here. But first, I just on sort of on the technical side, I was quite impressed with your non-gated results, because it sounds like we're getting very close to the idea of just not needing gating, period. I mean, basically, you were kind of saying they're equivalent. And so do you envision just at some point just not even doing dedicated coronary calcium scoring? You can just do it with an ungated situation?
Yeah, I fear more or less that it's important that it can be done indeed under very controlled circumstances. But if you just do it with the monosource system and non-triggered, that will really give you very poor results. Where you cannot. So here is a real. If you want to do it, a very high quality assurance system should be in place.
Yeah, but with that system, with these high quality systems, it sounds
but-
like you're getting awfully close. And
then
it's only getting better.
Yeah,
It's
then
only getting better.
then you do non-triggered. It's a lot better than monosource triggered. That's
Mm.
the situation.
I would point out though that all the imaging for the foreign lung run and the Robinska were done at specialized centers that were just set up to do research imaging. Is that correct?
Yeah, at that time, so when we designed the foreign lung study, we had only 3 centers in the Netherlands that had this system in place. And that's also why they were selected.
Okay, did I interrupt you, David?
No, but as a general principle, I mean, he's demonstrating the capability of these machines, the newer generations, to really do a great job. And I think that's really important, because this technology just continues to get better. And I think that's great to know, that those institutions can do it.
I think it's very important to put things in perspective. So those systems are extremely cheap compared to the impact they have.
Yeah.
Yes. David, Professor Maron, did you have any thoughts on the technical side of what Matthias just outlined for us?
Not, I don't come from any background that would permit me to ask a question about technical issues, but I would just underscore the importance of bringing to practice dual screening for lung cancer and for coronary calcium with the same test. In fact, going back to previous scans and looking for people who are at high risk, I think would be a useful exercise.
Yes. Yeah, the European literature on workforce preparation for screening is very disconcerting for continental implementation of screening. If in fact the impact in terms of the cardiovascular care with reduced hospitalizations across Europe approaching, was it 500,000 hospitalizations? I mean, it would have a profound effect on workforce, capacity. Matthias, what are your colleagues saying about those types of issues?
What issue you would like to focus on?
In terms of the reduced requirement for preventive interventions and the reduced hospitalizations associated with more careful calcium characterization of the screened population, that those numbers are staggering, and both in terms of dollar cost and in terms of the amount of professional effort required or saved.
Yeah, yeah. No, I think in the Netherlands, but that's of course the country I live in. They are extremely interested in those outcomes. They think there's a surge of unnecessary medical treatment in the Netherlands for all kinds of reasons, and anything that could drop down with a scientifically proven approach will be welcomed here in the Netherlands. There is no awareness, I think, in most of the countries that this can be done. So therefore, in the US, it's not for nothing that I had the only EBT system and the only calcification study, coronary calcification study in Europe. While in the US, there were many. So the interest in the United States has been, 100 times higher in this process of coronary disease than it was in Europe. So therefore, I think the direct impact will be realized far more early in the US than in Europe. So I think in this term, I think US will lead. Also, I think in cardiology, the impact of all the guidelines from the US on Europe is huge.
By the way, I noticed something in one of your slides where you talked about the impact, where you showed if there was this impact, the ratios of reduction in cardiac to reduction in hospitalizations was different in each of the three areas. So do you have any thoughts about that? It was like much fewer reduction in hospitalizations in the US relative to the reduction in heart attacks compared to Europe or.
Yeah, that is calculated just from the figures that are published in the public available data. So that's how the calculations are made. So
Very interesting.
they just look to the hospitalization figures per country in Europe. That's also and also from the US are public available.
Yeah.
And then you translate it to, but I think you fairly sharply noticed this.
Yeah.
Yeah. Okay.
Very
Professor
nice.
Marin, in terms of the impact in cardiology, preventive management, and related issues along the line of what Matthias outlined, what do you think is going to be the impact of these kinds of findings?
Well, I know our time is short, and I'm going to maybe not directly answer your question because I really want to ask this question about the trial. First of all, I want to say congratulations on completing this huge, ambitious trial. It's really an amazing accomplishment and a really important contribution to the field. I'd love to know when the main results are going to be presented. But here's the one big question that I have. You found that with the score, there were many more patients who were identified at being at high risk and needing preventive intervention compared with the CAC arm. And it speaks to how well coronary calcium can personalize therapy and target those at high risk. But isn't the purpose of the clinical trial to show that screening is the hypothesis that screening with CAC will reduce events, will improve prognosis in those people screened with CAC compared with other strategies? Did you, and you know the results, I don't, but it alarms me that many more people will be treated with statins and other preventive interventions in the non-CAC group that might undermine the ability to prove the hypothesis. What has been what is your impression and what's been going on inside the trialists' minds?
No, I think it's of course very hard to comment on this without, yeah, more or less already give some insights. But I will try to talk around it. So you can see that we are already looking for differences of only 15%. So that gives already an insight in our expectations. So we have huge cohorts, small differences. So what I can say that even if there are no differences in the mortality rates and no differences in the MACE rates, you have already a major result.
A quick question. Why did you not include stroke as part of the primary endpoint, since one would expect stroke to be reduced with this intervention?
Yeah, that is related to the endpoint itself. That if you really want to make that objective, you need an examination of the brain. And most of the TIAs and all those small infarcts and transient ischemias are very hard to objectify. So if you want to make that part of the study, which would be very interesting, yeah, in the US you would have the funding, but not in Europe. Funding is for all those studies a major issue in Europe. So if I think David Jankelevich and I discussed that several times. So I learned that the NLST was funded by $250 million. And our study, the Nelson, was funded not even by 10, so 9 million euros. So it's an incredible difference. It's hardly understandable and explainable, those differences. But with those kind of budgets, we cannot imply also together with such a study, which we would, of course, would have liked to do with an MR, extra of the brain in all those studies and so forth and so on. It's totally.
Jim, a quick answer to your question to me was it would have a huge impact if this is a quote positive, if Rubinsky is a positive trial. And if it's negative, it's going to, I think, just intensify the U.S. Preventive Services Task Force position that we need a randomized controlled trial to show a benefit before it can recommend screening of the population for coronary calcification.
Yeah, I think what I also showed, this major issue on the application of statins lifelong is of course, it should be answered at a certain point in time.
Yeah.
And a zero in your study meant no statins, regardless of whether they had diabetes or anything else. Zero was your low risk.
Yeah.
Did you do anything else, by the way, or are you planning to do anything else to go beyond the traditional zero with 3 millimeter slice thickness and to look, more comprehensively, because you have the data of thinner slices, things like that?
Yeah, we could do that. But of course, it's also a matter of workforce at the moment. So perhaps we can collaborate on this.
Sure, we'd love to.
Yeah.
We need workforce. Yeah.
So I'm pretty sure we're about out of time, or closing in on out of time. And I just wanted to thank all of you for your help in having this very, very interesting forum. We're going to be hearing a lot about this issue going forward. It has profound implications, as Matthias, I think you've outlined, and I think both Davids are very, very also confident about. And so it behooves us to really sort out these issues in terms of how generalizable are these results, and if they aren't generalizable, what the impact is, and how do we manage these outcomes in particular personalized types of groups, as David Marin had mentioned, to really get the maximum public health benefit from these powerful new tools. Unless there's a burning issue, I think we'll stop here, but we're going to have time at the during the workshop to have some more questions and touch on this from a lot of different directions. Thank you all for your help. Have a good day.
Thank you.
Thank you too.
Thanks.
So we're going to have a live segment now, and to kind of walk through this, David Marin rejoins us, Dr. David Marin from Stanford. And in addition, we have Dr. Toshi Okuso, who has helped us through this workshop forum over the last several years. It is a practicing preventive cardiologist at Rush and has kind of grown up professionally around these coronary calcium issues. And so I just want to start. We have a live segment. We have 16 minutes. I want to start and just see, David, having thought about this and potentially heard part of this presentation again, is there any issue that you would like to bring to our attention before we move forward with the discussion? Oh. And across from me in this room, we have David Yankelevitz, who also joined us, obviously, for this panel. And but I'm looking at the wrong screen, obviously. So still David Marin. Any additional issues that you'd like to bring up at this time?
Not really. I think that the Rubinska trial is, as you all heard, it's huge. And the way it was designed, I have serious concerns. So we'll find out as soon as they report out. But it sounds like it's going to prove the power of zero, which is very useful. But I'm concerned that it's not powered, despite the huge number, to prove that screening reduces events, cardiovascular events. So
Comparative group.
Compared with the risk score, and in the US, it would be either the pooled cohort equations or the PREVENT score, which is the new cardiovascular risk model. That's my only comment about Rubinska.
Oh, thank you. Thank you. Toshi, thanks for joining us this morning. We've been hearing a lot of this from a technical and epidemiological perspective. From a clinical implementation perspective, Dr. Kelly is saying in the video that it looks like the technology is getting better, and so the acquisition may be non-triggered in the future and stuff like that. From a adaptation perspective, do you anticipate that this is going to be something that's welcomed by the cardiology community, or what do you think the primary care people? You've been working with calcium scores for a number of years already. How do you think this is going to play in the minds of the people that you hope will be interested?
Thanks, Jim, for inviting me. And I'll just say that I'm not a practicing preventive cardiology, even though I have some training in it. My focus is cardio-oncology, which is heart disease in cancer patients. But I think I do use, as Jim and I have talked discussed quite a few times, I do use the coronary calcium in my patients. I think my patient population is unique compared to the rest of cardiology because my patients, most of them have had some sort of cancer, either surveillance or diagnostic chest CT scan of some sort because of the malignancy or staging CT scans. And so most of them have had, because they've all had chest CT scans, I tend to pull up their chest CT scans and evaluate for coronary calcium, and then use that in helping me assess their risk level and the need for possible escalation of cardiovascular therapy and cardiovascular care. And I'll say that in the past, there was always some debate about whether we should put patients on cancer treatments, on statins and all that. But I think more of the data is coming out that's showing that statins are useful when we're talking about cancer disease, cancer progression, cancer recurrence, and statins are also useful overall from a cardiovascular disease standpoint to reduce the cardiovascular disease risk while the patients are getting their cancer therapy. And so we have a lower threshold than we used to start our cancer patients on statins. And so the CT scans are usually useful to me in making that decision in addition to their lipid profile. And so, how to answer your question, Jim, how do I think that this trial is going to influence the cardiovascular community? I don't think it's going to influence what we're already doing much, honestly, because I think right now we're not screening for coronary calcium in everyone, right? I think most of the cardiovascular community is selective about who they screen, and that's based on the guidelines. It's selective about who they screen for coronary calcium, and that is usually patients that have some level of risk, generally intermediate risk. So patients whose lipid profile may be normal, maybe they have a family history of cardiovascular disease or something like that, and you want to go beyond what the risk scores would use in assessing these patients and get some extra risk assessment. Those are most of the people that many of us under normal circumstances would decide to screen for coronary calcium with. And so universal screening is not something that the cardiovascular community embraces currently, and I don't see that that's going to be something that is going to be embraced in future.
No. Okay. Thank you, Toki. Thank you very much. David Yankelis, any additional comments from your session that we just visited?
Yes, I want to, maybe put an exclamation point on what Dr. Marin said in this trial. And I'll give you the example. If everybody in the control arm was deemed high risk and treated with statins, there would absolutely not be a mortality benefit compared to the screening arm. So, and if mortality reduction is our primary endpoint, I'm very worried that we won't see, as David pointed out, we won't see the mortality reduction that we hope for. So we will have to look for other things, in particular, the power of zero. But to also stress then that all of that result will come from the single CAC arm, the coronary. The randomization won't help with that. No. The randomization aspect of that is, I think, not going to be useful. It'll all come from the screening arm. We'll get all the information about the CAC 0 from that arm which was screened. So I am very worried that if we get a zero, we don't get a mortality reduction, this will be held against CAC scoring.
So recall though, Babinski has 3 arms. So there could be an ability to look across the arms for contamination, kind of statin contamination, if you will. But that's a very good point. We do have listening in to the Zoom, Morton Nagavi, Dr. Morton Nagavi, Moteza Nagavi, who just recently published a paper on, as David's group has, on AI assisted coronary CAC. Mort, I hope you're there. Any preliminary comments before we get into the questions from the group?
Hi, Jim. I don't know if you can hear me.
Yes, perfectly.
Okay, great. Well, I would just echo what the 2 David professors said, and that I think the design of the way our European colleagues do in their trials really not American in the way of, we would approach for screening, the way we would invite our targets. I don't know if you can still hear me.
Yes, perfect.
So I share their concerns that Rubinska might push us a little backward as we were just getting momentum if the results is just for power of 0. of course, we are trying to get Medicare to understand the power of zero and understand the value that CAT scan provides is more than just coronary artery disease assessment. Coronary disease or atherosclerotic cardiovascular disease is about 60% of our mortality. 40% are other things like heart failure, atrial fibrillation, stroke, and as David Marin brought up, and our colleague at Robinska, brought the budget problem. They didn't include a stroke. It's a big problem as part of the overall ASCVD. So just a cautionary note that we can't bank on just power of zero to save lives. Power of zero saves 0 lives. That's my point. What we can, it saves money. It saves a very wrecked up healthcare system that is pouring money on lack of ROI. But power of zero doesn't save life. And we need to, if we want to save life, if we want to reduce unpredicted events that could be easily prevented, preventable death, we would need to do a better job of reaching people who are high risk and completely unaware, walking around, not just for, as you said, in our Nature paper, which both Davids have contributed, not only for coronary artery disease, but also for heart failure, for atrial fibrillation, for stroke, and then along the way, opportunistic findings related to fatty liver and diabetes by virtue of excess visceral fat, osteoporosis, emphysema that leads to COPD, all of those about which I think the Dutch team did a great job. Matthias, what his foreign lung trial to look into other things, but I think they're still limited. They narrowed their focus perhaps a little too narrow. It could have gone broader and touch all the areas that a chest CT based screening can reach to improve primary prevention. Again, our goal is primary prevention, so that's what we're hoping to achieve together. So I'll stop here.
Yes, thank you, Mark. So we see that there's a lot of passion around these issues and a lot of particular concerns. This is a big issue. And I think, like any of the situations, one size will not fit all with one trial result. And so we're going to need additional trials to flesh this out. We look forward to the mortality outcome from the Babinska. And I think we're out of time. We had a technical question, which I will forward to Dr. Utkirk to get a response back. And I think we have to move forward. But thank you. I want to thank all the panelists, Toshi, David, Matthias. I hope he's traveling safely at this moment in time. And this is a topic that we'll continue to engage in because it's of such profound preventive importance. So thank you very much. And
Thank you.
thank you. And our next up is a short break, and then we're going to come back to the Leadership Award, in which we will be recognizing the accomplishments of Nancy Obachowski, and we'll be back in a few minutes. Thank you all.